Hi, my name is Alicia Herndon, and this is going to be my voiceover for the PowerPoint for my presentation on meconium stain amniotic fluid as well as meconium aspiration syndrome. So, first let's talk about meconium. Meconium is gradually accumulated in the intestines around 16-week gestation, and it's also Greek for poppy juice or opium-like. And so meconium is believed to lead to neonatal sleepiness or depression. And meconium stain amniotic fluid is also considered obstetric hazard, right? Because it is a viscous substance that can cause destruction to the airways. The most common abnormal findings in newborns are respiratory related. Aspiration of meconium is one of the most common pulmonary causes of neonatal respiratory distress in term infants. Pneumonitis, hypoxia, respiratory failure, and persistent pulmonary hypertension of the newborn can all be a result of developing meconium aspiration. Even in stillbirth infants, they have been found with meconium in the alveoli of the lungs, which shows that the fetus more than likely potentially begins to gasp in utero, causing aspiration. Some risk factors of meconium stain amniotic fluid, which is also present in 5 to 20% of births. Risk factors include post-term pregnancy, prolonged labor, and also I want to mention in first-time moms, it is the second stage of labor. When it is prolonged, it can also aspirate fetal distress and increase meconium staining. And so more risk factors: clinical chorioamnionitis, fetal growth restriction, preeclampsia, oligohydroamnionitis, if I pronounced it correctly, vaginal breech delivery, maternal drugs, which include cocaine, castor oil, bowel purgatives, and even some herbal substances, as well as intrahepatic cholestasis of pregnancy. All right, so those are some risk factors. And so when the fetus has lack of oxygen, hypoxia, or asphyxia, that phenomenon relaxes their anal sphincter and produces meconium stain amniotic fluid. Now, I'll also speak about this later, but there are also other sources that speak about just the maturity of the fetus and its GI system, which would cause normal bowel movements in utero. So, although 95% of infants that have meconium stain amniotic fluid do not develop meconium aspiration syndrome, the 5% who do develop meconium aspiration syndrome are at risk for developing chronic lung disease, neurodevelopment delay, especially if it is severe. Meconium aspiration syndrome, in its mild cases, some infants respond well to IV antibiotics and warm humidified oxygen. Also, the infants seem to be congested but not otherwise compromised. Providing steam from a shower and percussing on the lungs to help release meconium is appropriate. All right, and I also wanted to speak about there is a systematic review of randomized controlled trials that suggests that amnio infusion may decrease the rate of meconium aspiration syndrome. So the histologic examination of the fetal membrane for meconium has been invoked in medical legal litigation time to the occurrence of fetal injury. And so that's just something to kind of consider. The inference have been largely based on the results of in vitro experiments, and exploitation of such findings to clinical settings warrants caution. All right, just a little bit more about some different studies that have been published on management of babies born with meconium stain amniotic fluid, and there's lack of agreement into the physiological origin. And again, one theory is that the stain occurs as a result of fetal asphyxia, like I said earlier, and it has been historically been associated with fetal distress and perinatal death. But others do look into meconium prior to birth as a normal physiological sign of mature fetus, as associated with fetal maturity. And so I want to talk about some of the following endocrine factors that have been implicated to increase frequency of meconium passage as term. So Motilin is the gut hormone produced by the enteroendocrine cells in the duodenum, and so it's capable of inducing intestinal peristalsis. The concentration of Motilin is significantly higher in umbilical cord blood from term infants than from preterm neonates and those with meconium stain amniotic fluid versus clear fluid. All right, another hormone is cortisol, increases in fetal plasma at the time of parturition and can also induce intestinal motility, as demonstrated in a study of pregnant monkeys. And so in that study, they saw intraamniotic injection of glucocorticoids resulted in meconium passage. All right, and so another hormone is the corticotropin releasing factor. That's a hormone that increases with gestational age as well, and that can accelerate the fetal gut mobility. And another thing to note, most neonates born to mothers with meconium stain amniotic fluid, they do not have evidence of metabolic acidemia at birth. And so just the rate of meconium stain amniotic fluid does increase as function of gestational age and can reach 27% at 42 weeks gestation. So it is true that most meconium stain fluid babies are well with no evidence of any adverse effects. I still just want to really talk about what are the prudent actions that a midwife would need to take. And so to really help combat the severity of meconium aspiration syndrome. And so when MEC is present, it is prudent to even observe the neonate 12 hours after they're born and have meconium observations, which would include monitoring the baby's color and tone and respirations, because increasing cyanosis and respirations above 60 are signs of illness for meconium aspiration syndrome. And so, but once the meconium is even noticed in labor, one of the first things that needs to be assessed is the color to differentiate, is it old meconium or new meconium? So old meconium is going to be yellow, and that proves that the fetus had a brief hypoxic episode prior to labor. And if it is fresh, it would be brown or green, like pea soup. And so it is evident of recurrent or recent fetal stress, increasing heart rate monitoring, and an essential, heart rate monitoring is essential for several contractions to find any of the slightest deviation from normal. All right, another essential layer to evaluate is the thickness of the meconium. And so if it's a significant amount and it's in thick lumps, then that is the time when transferring is wise and appropriate if birth is not imminent. And so if meconium appears to be light, then it is recommended to have continuous fetal monitoring and transfer if the mom or baby shows signs of compromise. In presence of meconium stain fluids, planning for nasopharyngeal suctioning was once an imperative thing to do, and in some cases, some probably would still argue that it is. And so you do suction at the perineum before the head is born, but before the body is born. After the head is born, but before the body is born. And that has been considered standard of care. And the lead is recommended to be used, and it's advised to ask the mother to breathe through her contractions and not push while the suctioning is ongoing. However, there has been, conflicting studies where one study showed where 2,000 infants who all had meconium staining in their fluids, and they had randomized suctioning, and there was apparently no difference in who developed meconium aspiration syndrome. And so this theorizes that it's possible that meconium aspiration syndrome is caused by an early incident in severe depression in utero. And also just routine nasal or pharyngeal suction and tracheal intubation in case of meconium stain amniotic fluid hasn't been all the way beneficial in most obstetric practices. Babies come with laryngeal lesions leading to stridor or hoarseness, bradycardia, apnea, hypoxemia, and desaturation were reported. And so there are some recommendations to where management should just be guided to general neonatal resuscitation principles rather than suctioning. Another study that I came across, it showed that the highest, we know the high proportion of meconium stain fluids is going to be post-term. And so there was a study that was looking at different cultures and ethnicities. And so the differences in gestational length amongst ethnic groups have been demonstrated in a large cohort study comparing Black ethnicity, white European, and South Asian ethnic women. And their study, nearly 500,000 women found the rate of meconium aspiration fluid was actually higher for Black ethnic women and South Asian compared to white ethnic women. And so to answer the question, why is this pertinent to midwifery care and how would it influence my future practice? Because of the so many unknowns, I've always been wondering, what did our ancestors even do in presence of meconium? And just the idea that we're still getting a foundation understanding of the just the whole physiological process of how meconium and why it happens and how to prevent it. It really makes me want to observe even more in the term period with moms, and also just being able to help moms have a sense of peace and calmness to help prevent neonatal distress if that is a factor outside of the maturation of the fetus. That's something that I feel like we can't truly do anything about it, but at least keeping the mom calm and doing what we can to help reduce the stress of and that's mainly when it comes to prolonged labors. And that's just, yeah, I just really want to be able to notice and be quick when meconium is present, because again, even though 95% are fine, that 5% is still a little bit more to kind of discover and see how we can even lower that percentage, right? And so thank you, and here's my PowerPoint to follow.